Winter is coming. Make sure your car is ready with Carry Car Care. Family owned and operated, they'll keep you safe on the road all season long. Give us a call at 919-380-0040 to schedule your winter service today, or visit us at carrycarcare.com. Carry Car Care. It must be right, or we'll make it right.
Hi there, and welcome to What's Up Wake.
Spend your day is the only way. Take a break with What's Up Wake. Ooh, What's Up Wake.
Presented by the publishers of Carry Magazine, Wake Living, and Main and Broad, What's Up Wake covers the people, places, restaurants, and events, essentially all the cool stuff and great news of Wake County. I'm your host, Melissa Wistahuff. Join me as we find out what's up Wake. Hi, everyone, and welcome to What's Up Wake. We are continuing our month of New Year resolution episodes, and this week we're focusing on women's health. We're diving into that special time of life when your mood, your sleep, and your thermostat are all competing for who can act up the most. Some call it perimenopause. I call it a game of tag between every emotion known to mankind. We're in luck because we have Jamie Gallagher here today. Jamie is a board-certified nurse practitioner and perimenopause specialist who started the uber-popular Peri and Pause Menopause Center in Fuquay Arena, now with a second location in North Raleigh. She is featured in a story in our November-December issue of Main and Broad, so I had to get her here to help make sense of the chaos and bust some myths. Welcome, Jamie. Thank you so much for being here today.
Thanks so much for having me. I appreciate that.
I have so many questions for you, so I'm going to talk like 100 million miles a minute trying to get it all in. Before we get into what's normal, what's not normal, and how we get through it all without hurting someone, tell us a little bit about yourself and why you chose to specialize in perimenopause and menopause care.
Yes, thanks for that. I am a family nurse practitioner, as you said. I am a mother of 4, grandmother of 3. I've worked in healthcare for over 30 years, in primary care as a nurse practitioner for the last 16 to 17 years. I would say about 5 years ago, my own personal experience with changes in my body, changes in how I thought, how I performed at work, changes in just relationships and other aspects of my life had me wondering, hey, is this time occurring and are these the symptoms? And when I sought my own care from my own providers, I realized that they didn't know much more than I did, which was kind of frustrating. And then as a family nurse practitioner and primary care provider, once I learned more about perimenopause and menopause and how it impacts our bodies, I could not unsee it in every woman that was sitting on that exam table that I only had 10 minutes with, 7 minutes with, 15 minutes with. So with the encouragement of my husband, as he inched closer to retirement from the military, I decided to branch off and open a clinic completely specializing in midlife women's healthcare as it surrounds perimenopause and menopause.
Well, we thank you very much.
Well, thanks.
Because maybe I'm wrong. Maybe it's the cynical side of me, but it feels like our OBGYNs don't really know much. I heard that they really don't because they don't focus a lot of their training on menopause, perimenopause. And it kind of seems like it's a suck it up mentality that you go and they're just like, oh, it's just normal. Everybody goes through it. Well, just because everybody goes through it doesn't mean that we can't have some sort of relief and be able to treat some of the things that we're going through. Right. So do you find that, you kind of just said it, do you find that OBGYNs don't really know a lot, and why aren't they trained?
I would say this started back in the late 90s, early 2000s with the publication of the Women's Health Initiative. That completely derailed hormone therapy for midlife women. I believe it's greater than 40% of women around that time in the 90s were on hormone therapy that were postmenopausal. And when this study came out, it had some misinterpreted data that was, quote, almost statistically significant as it was related to breast cancer. And the actual information got to the media before it was even published in the Journal of the American Medical Association. So, wake up the next morning, hormone therapy causes breast cancer. Oh my gosh, like it was all over the tabloids, in the news. And nobody walked that back. Nobody looked further into this that actually ended up being published. So that was kind of the beginning of the end for hormone therapy for midlife women, because fear started surrounding that. So
and I feel like it is cyclical with things like that, because, 1 year you'll be told that, I don't know, eggs are great
right.
for your heart. And then, 2 years later, it's like, no, eggs are terrible for your heart. And it does seem like it's hard to keep up with following what everybody says that they suggest that we do.
Right, exactly. So,
but that's a long time. You said that was 30 years ago.
Yeah, a little over 20 years ago.
Okay.
So, in that same vein, menopause is normal and natural. And if we're fortunate enough to live this long, we're going to go through it. So I think the thought was we could possibly harm women. So that is the bottom line. We could possibly harm women. No one wants to do harm, but what we've done is harm in the name of doing no harm. So from that point forward, it was kind of removed from curriculums. If it was in curriculums prior to that, I'm not certain. But it was, here are the reasons you might treat a woman in menopause with hormone therapy. It is, night sweats, hot flashes, mood issues. And what you would want to do if you were going to do anything is use the lowest amount of hormone possible for the shortest amount of time. So it's kind of like, was it bad? Was it good? You give her a little bit, is a little bit good, and not bad is giving her nothing and letting her suffer in her body change and her relationships and her career and all that, go to the wayside. What is best for her? So because it's normal and natural, my thought is that, why would we intervene? So truly, when you're speaking specifically about OBGYNs, it's not for the lack of wanting to provide care. It's truly the lack of education. And it's hard to undo what you have practiced like for 20 years. To kind of walk that back and go, you know what? Everything I've ever learned or not learned that I've practiced now is kind of being removed. And how secure am I in that? In, shifting gears almost 180 and going, well, you know what? Actually, it could benefit you. So that's hard. And it means that you have to seek out extra education. You have to seek out information. And with, healthcare the way it is today, healthcare providers that are working full time have limited time to seek this information out on their own, to unlearn what has been taught for the last 20 some years.
And even then, it seems to me, and I talked to you before we started, a good friend of mine, Ashley, and Ashley is also a doctor, to be clear. She and I were talking about meeting with you today, and she wanted me to ask you about why it seems like doctors are so all over the board. Nobody seems to agree, but it sounds to me like what you're saying is still kind of so new in terms of we were told, do not do this, and now people are researching it, coming to an awakening period of saying, okay, well, maybe we should, but some people are still with the old mentality. I am a breast cancer survivor. Mine was a hormone positive breast cancer. And that's a long story for another day. But as far as estrogen goes, I came to Perimenopause, saw a different provider there. But I came to Perimenopause, and what she told me, and please correct me if I'm misinterpreting what she said, because I'm not the best at doctor talk. But she kind of said that in cases like mine, it is worse to not have estrogen, more dangerous to not have estrogen than it is, like, the likelihood of your cancer coming back if you do have estrogen, because of the things that the lack of estrogen does to your heart and to your body over time can be more detrimental. Am I interpreting that right?
That is, I am not a breast cancer specialist by any means, but that is definitely, that's what I think needs to be researched number one right now, one of the first things. I would say the number one killer we know of women is heart disease, hands down. You put every cancer we die from in one big bucket. The bucket of heart disease is still huge.
And a lack of estrogen makes that a lot worse,
contributes to that. The lack of estrogen contributes to that.
Okay.
There's a lot of words right now with the unblanketing of the boxed warning. So the word prevent and risk reduction, those words do not mean the same thing. So when it comes to hormone therapy and breast cancer, it is individualized, nuance to the woman. What is it based in? It's based in science, but it's also based in shared decision-making with the woman. So there are women that have had a history of breast cancer that could possibly be candidates, but you want to work closely with oncology to make sure everybody's on the same page with the same evidence. Because over, these last few years of being heavily involved in menopause care and, with menopause thought leaders, being members of certain societies and organizations, what we have realized is that oncologists practice in their solo and we practice in our solo, and never the two shall meet until recently. So there's a lot of, I hate even to use the word controversy, because just the word controversy in women's health, it's what other thing in healthcare causes more controversy and more high emotions than women's health. Barring pregnancy, it's definitely midlife women. So truly, oncologists want to save your life. They don't want you to die from cancer. We don't want you to die from cancer. We want your quality of life to be super high after cancer. So we can't forget that gap between survivorship and quality of life. And it really should be a solid conversation between a healthcare practitioner and the woman, and a healthcare team approach to that.
And speaking of healthcare team, one thing that I found through my cancer journey was the different parts and pieces don't talk.
Yes, absolutely.
Even though my doctors were all, with the exception of one with UNC, none of them really talk to each other. There's notes in the computer, but there's a lot that falls through the cracks because of that. So my oncologist doesn't really talk to my breast surgeon, doesn't talk to my radiologist, and certainly, I haven't put them in touch with my provider at Perimenopause, but and I feel like it would take an act of God to do that. But it really does seem like there's so much with healthcare that does fall in the cracks, that it leaves people feeling desperate and feeling alone.
Absolutely. Breast cancer survivors have been known to not be truthful about their medical history to get hormone therapy because their quality of life is that poor. And
that's really sad.
Absolutely. That devastated me to hear. It did not cross my mind that was actually happening.
Oh, I believe it 100%. I have started with the testosterone route. Just started it. I think it takes a long time, for testosterone to show any effects?
It depends. It can be a few weeks. It can be up to 4 to 6 months.
Yeah. So let's talk about the 3 branches of the HRT. Is HRT, that's question number 1, actually. Is HRT, is that a combination of the 3, or does HRT mean we could be talking about estrogen, progesterone, or testosterone, or is it combined? Let's talk about that first.
Absolutely. Let's, because I was in a live Zoom session the other night where this was a topic, and the arguments of what it should be called. I was like, are we getting anywhere with this meeting? Is it hormone therapy? Is it progesterone, estrogen, testosterone therapy, PET therapy? Is it menopausal hormone therapy? Is it hormone replacement therapy? I'm just going to call it hormone therapy going forward.
Okay.
But hormone therapy is also used in the breast cancer realm for, types of endocrine therapy, things like that. So hormone replacement therapy, I think HRT, when you think HRT, that's when people go, huh, because that is the acronym that was used during the Women's Health Initiative. And then it shifted to menopausal hormone therapy. But what about those years before, when you're 42, clearly perimenopausal? Are we giving you menopausal hormone therapy? So again, acronyms can be used in different ways, but for all intents and purposes, right now it's technically menopausal hormone therapy. So MHT, HRT, whatever you want to call it, whatever resonates with you, I think it's fine.
And that's really just an all-encompassing acronym for any type of hormone therapy, medicine, treatment that you're given.
Yes, for perimenopause and menopause, yes.
Okay.
Any of them, you're not wrong, I guess I would say.
So if somebody says to me, I'm on HRT, it really could mean that they're just on testosterone or just on estrogen.
I would say if someone said that to me, I would presume it was estrogen and or progesterone, meaning, together or separately, depending upon the woman. Testosterone isn't FDA approved in the United States for women. That only means it is not FDA in the approved in the United States for women. It is in other countries, South Africa, New Zealand, Australia, the UK. It will eventually be here at some point. But in the meantime, is that when someone says I'm on hormone replacement therapy, most people don't think, oh, that's testosterone as well, even though that is a significant and integral part for some women when we're treating them with estrogen and progesterone.
Okay, so let's talk a little bit about the difference between perimenopause symptoms and something that could be more serious and you should really seek medical attention. Because some perimenopause symptoms I have found might feel and could be something different, like
Absolutely.
Rapid heart rate or, a difference in fatigue levels. So how can you tell what it is?
Exactly. So when women come to us at Perimenopause, my number one rule is just because we have a menopause hammer, everything is not menopause. So we must look at the whole woman, all of her. Her mental health, her physical health. What are her symptoms? A lot of symptoms that are similar to medical conditions that need treatment are perimenopausal symptoms as well, such as like you were talking about, palpitations, racing heart feeling is really, really common in perimenopause. But you don't want to miss that woman who has an abnormal heart rhythm or atrial fibrillation or something that does need an intervention. So you need a good head-to-toe assessment, a good medical history, surgical history, family history to put that together to see the whole woman. We find thyroid disorders all the time in midlife women's care.
Yeah, I have found that because I also have thyroid. I'm just a trifecta of wonderful things.
Hormones.
Yeah. But I have found that thyroid symptoms really do mirror a lot of the perimenopause symptoms.
Absolutely. So women will typically go to their primary or other healthcare practitioner and say, I have midsection weight gain, I am tired, my hair is thinning. And you will get just routine labs, including a thyroid, and the majority of the time, that is normal. The absolute majority. I've seen it in practice for years. And it's almost like a ticket to go, you know what, your labs are fine, everything's fine. It's probably just aging. I'll see you in a year. But nobody's talking about, okay, so it's not this, which is awesome. So let's talk about menopause and what you can expect head to toe, from hair thinning to ears ringing to dry eye to teeth changes because your jaw is changing to heartburn to palpitations to shortness of breath to muscle loss. I mean, I can just keep walking down the body. But what a good practitioner will do is investigate concerns. But I think perimenopause brings in symptoms that are vague, and midlife women come in going, I don't feel like myself. Those are the classic words because a lot of women don't know how to express that. What do you mean you don't feel like yourself? I don't know. I can't think of words. My mom had dementia and I'm petrified I had dementia. And, you get that routine labs, you're fine, but then you want to go, excuse me, doc, I know my labs are fine, but I'm definitely dying of something and you need to find it.
Yeah.
Like that's a lot of how these women feel.
And it's scary too.
Absolutely.
If you're not able to put a name to something and put your worries to rest.
Yes.
Because that's a big part, I think, of the whole perimenopause movement. I'll call it a movement.
Yes.
Because just very, very recently, it's become more in the mainstream of topics. We have Halle Berry that has come out and she's been very vocal about her struggles with it. Oprah had a big special on it. My very favorite social media personality, I'll call her. Her name is Melanie Sanders. I wrote that down. I think it's Melanie Sanders. She started something called the We Do Not Care Club. If you guys have not followed Melanie and the We Do Not Care Club yet, look her up. She is just being Melanie on Instagram. She is a breath of fresh air. because she is so funny about it, but she's also real, and she talks about her struggles. And I think that a lot of times, we're in the whole mind frame of, oh, we don't care what these celebrities have to say about X, Y, and Z. But it also does help because it's brought it more into the open conversation that women feel like, oh, we don't have to be silent about this. We don't have to keep this to ourselves and struggle. Right. So now we're able to, you're able to start something called Perimenopause, and it gives women an outlet to say, okay, we don't have to be like this.
Exactly.
We don't have to be miserable.
Right. When women come in, I would say probably at least half of that first visit, just the validation and someone saying, being able to finish a woman's sentence for her. And she's like, that's it. Exactly. Yes. And it's almost like they exhale and feel heard, which I'm telling, there's something about just being heard that is therapeutic, that makes those symptoms less terrifying, for lack of a better word.
Yeah.
You know what? This is normal. This is treatable. And it's okay for my symptoms to be treated. Why? Because I want my quality of life from this point going forward to be as high as it can as I enter likely the second half of my life without my hormones.
Yeah, because it is a long period. We're not talking about just a couple years decades. Of misery. We're saying this could last us the rest of our lives.
Yes. So, how do you like your urgent care? At Wake Med, we have urgent care just about everywhere. Urgent care that specializes in orthopedics and kids. My Care 365, open every day of the year. Even virtual urgent care. Yup, urgent care in your jammies, on your tablet. So download the Wake Med All Access app and get urgent care that's caring, convenient, and just the way you like it.
Welcome to Podcast Carry, professional podcast studios with more than 50 shows making podcasting simple and fun. It starts right on our website. Pick a time that fits your schedule, tell us what you're working on, and we'll take care of the rest. You focus on the conversation. We handle everything else. Because starting a podcast should be fun, not complicated. Come see how easy it can be at podcastcarry.com.
Do you say that there are certain people that should not take hormone replacement therapy? And if they should not, what are some alternatives, maybe supplements or natural alternatives that people can be doing?
Yes. A few patients, vast majority of women can safely take hormone therapy. Let me just state that right out of the gate. Those who can't are clearly hormone receptor positive cancers, because that needs to be taken care of for life-saving purposes. If you have abnormal or unusual uterine bleeding, vaginal bleeding, that needs to be evaluated, absolutely. Severe heart or liver disease, we need to get that taken care of. And also, if you have an acute blood clot right now, if you have a bleeding, or a clotting disorder, that does not bar all hormone therapy. That at that point, that woman is better off with a transdermal estradiol patch. Doesn't go through first pass liver metabolism, doesn't increase her risk of clots, under 0.05 at this point. But when we take something by mouth, like an estradiol tablet by mouth, it does go through our liver, which can increase our clotting factors just a little bit. But and the risk of a clot with that compared to birth control is about half of that of birth control. But it's interesting how birth control is so freely given to perimenopausal women rather than, a hormone replacement therapy one that would be something that she could be on longer, that literally just supplements her own hormones with natural hormones, because the patch, progesterone, those are bioidentical, body similar, whatever word you want to call it. And the synthetic birth control pills are not. They take over our hormones. But hormone replacement therapy with the bioidentical patches, progesterones, testosterone creams, those match our body a lot better and can be used long term.
That's actually another question that my friend Deanna asked, which is, can birth control or IUD be as helpful as HRT? But you're saying that that they are different.
They're
and
different.
Can you be on HRT the rest of your life, whereas you shouldn't be on birth control that long?
Yes, that is kind of the standard of practice now. Hormone replacement therapy at this point, we're undoing kind of the myth that it needs to be stopped after 5 years or it needs to be stopped by a certain age. Because what happens when you stop it, and there's evidence in bones specifically, is that it returns to as if the woman has not been on the hormone therapy at all. So what happens to the brain cells, the heart, the vessels, all that? If we know when a woman stops hormone therapy that her rapid bone loss starts pretty quickly after that, but does level out, why aren't we studying heart, vessels, brain when she comes off of hormones? So all that to say that going forward, again, nuanced shared decision-making between a healthcare practitioner who knows how to treat menopausal and perimenopausal women. How is the key word here, that can walk with her through the latter decades of her life safely to keep her healthy.
It was in the news recently, and you mentioned this briefly, about the black box warning that it has been taken off of HRT. I guess I don't get it, why that's even significant, because the black box warning was literally just a warning on the package, right?
Yes.
I don't read those anyway.
Right. Some people do. Let me tell you.
So now that it's taken off, I mean, the big deal is what?
The big deal is this, in kind of the circles that I'm in, it was back in 2002 or what have you, a blanket black box warning was put on all estrogen-containing products. Even vaginal estrogen, saying breast cancer, blood clot, heart attack, stroke, probable dementia, from literal cream, vaginal cream that helps those symptoms. I mean,
so the things that scare you to death at the end of the commercials.
Yes, absolutely. So what happened was the FDA undid all of that. We were literally only expecting that it was going to come off of vaginal estrogen, but when they undid it for all estrogen-containing products, I personally, deep in my soul, saw that as a huge win. But I also saw that, this can be misinterpreted in that there is a difference between oral estrogens and transdermal or topical estrogens, different type of estrogens. So it still absolutely needs to be prescribed or used to treat women from someone who knows how to prescribe this based upon the individual woman. But I think in general, it was a win because if you look at the bigger picture, it removes the unnecessary fear. And there has been so much unnecessary fear to the point that...
they'll scare you to death.
Yes.
Especially when you are diagnosed with breast cancer. You are scared into submission.
Yes.
Truly, over everything. And then you start hearing the flip side of taking things like tamoxifen and having chemo and all the treatments that they truly insist that you do.
Yes.
It's not much of an option. It's like, this is what you're doing. This is the course. But then you leave the doctor's office, and then you have another group of people that scare you to death about taking it.
Yes, exactly. That's where we have to get together as a team for the benefit of midlife women and stop being siloed. Even in 2013, I can't think of the physician's name. He published in... Can't think of the journal either, but was saying between...
That's the brain fog, every
brain
frog.
Brain alive fog. And well. That between 18 and 91,000 women, when they looked at the placebo arm of the Women's Health Initiative, died. These were ages 50 to 59, if I'm not mistaken, that had hysterectomies and were not offered estrogen therapy, that between their guesstimate literally, was between 18,000 and 91,000 women died prematurely because of them not being offered an estrogen. And that was 12 years ago. Where was that 12 years ago in education? Why was that not, making the news? Hey, maybe we should relook at this Women's Health Initiative. But it's been lost since the Women's Health Initiative. There's lots of evidence out there for the support of hormone therapy, but it's not in one place. And I think that has made it that much harder for general practitioners, OBGYNs that are delivering babies, doing well women, doing surgery all day, every day. It's not in one place.
Yeah.
And so that's what makes it hard.
Well, and I also think it goes back to what we were saying about how it's more in the open dialogue now, and people are so talkative about it at this point. Yep. So, and you got to rip off the Band-Aid. They ripped off that black box warning, and it really got a lot of attention.
Yes.
Yeah.
Yep.
Okay. So we're getting near the end. we have so many things that I could still talk to you about. I'm going to have you back.
Yes.
This is one of my favorite segments of What's Up Wake, and I don't do it very often, but I call it Ask What's Up Wake, where I ask my personal Facebook friends, which
Nice.
we're all in perimenopause together.
Can I join?
So they jumped.
I need to be your friend.
Yeah, they jumped on this one when I said, "Hey, I'm meeting Jamie Gallagher. What should I ask her?" They were like, "What?" Okay. So Tanya sent me a lot of questions. I think we covered all of those. I'm going to skip you. Love you, Tanya.
Love you, Tanya.
Hannah, she wants to know, well, I think we already answered this too, because she asked, once you start HRT, how long should you stay on it? And it's essentially
ongoing till further notice.
Becky, on the flip side, Becky is my mother. Hello, mother. Love her very much. She is 68, and I think she fell in that area of time when they did not recommend it anymore.
Yes.
Even though she had a hysterectomy at a young age, they still didn't put her on anything.
Right.
So she's wondering, is it too late to start HRT at a certain age?
The answer to that is it is nuanced. It's never, I don't want to say it's never a hard no. It's most commonly not a hard no. It is very individualized. The thing with that is why there's a window, or there's considered a window, is because at some point things can't be reversed, like heart disease. Your new hormones aren't going to reverse that heart disease. The FDA or the U.S. government doesn't. It says that estrogen therapy is used to prevent osteoporosis, but not used to treat. Well, in other countries, it's used to treat. So there's a lot of nuance. So we can't just close the book on a certain age. But with a solid health history, a good visit, good assessment, what symptoms you're experiencing, what could be better for you, it's definitely, I truly think every single woman deserves this conversation, no matter what age. And I truly think it needs to be a part of Well Woman visits starting at age 30, 32. To be at least bring it up and plant that seed. You know, hormones change. You are very young now, but be looking out for these symptoms. But as far as age, it is very individualized still to the woman. That age 60 or 10 years out of menopause is not a slammed door in your face.
Okay, Jenna asks, are there any natural supplements that actually do something to help particularly fight anxiety and brain fog?
Oh, yes. So sleep.
Other than marijuana or...
That's right. Well, there's some things.
Wine.
Yes, exactly. Wine, let me just call that out, is sadly not our friend in any way, shape, or form.
You know, I was going to ask that, and I took that off my list, Jamie.
You did? We'll talk about that later.
There's certain things I just don't want you to tell me.
We're not going in that negativity today, sis.
Yes.
So natural. Sleep is hands down the number one thing. And lots of women are like, well, that'd be nice. I wish I could will myself to
because
sleep.
that's one of the symptoms that many people experience.
Yeah, exactly.
And then we're told, don't take melatonin, don't take this, don't take that.
Melatonin's great. And then the next day it's not.
It's
we're
not,
back
exactly.
to the, Are eggs good or eggs bad? So sleep is first and foremost something that we need to focus on, but it is very hard as midlife women. We are at the top of our game in our career. We have teenagers, we have aging parents, we have relationships, we have all the things. And when our stress isn't managed, poor sleep, that's when anxiety picks up. But also that new anxiety, those new panic attacks, those new, I'm in the back of Target, I'm going to get some new Christmas ornaments, and all of a sudden it's hot and I have to get out of here because I don't know what's happening to me. That is because of the chaos of hormones. And speaking of natural supplements like foods, rest, yoga, meditation, all that is great. But when the source of that is because of fluctuating and declining hormones, what is more natural? Think about this. What is more natural than your natural hormones to help that? And with estradiol patches, micronized progesterone specifically orally, that gives your body back what it needs to help regulate dopamine and serotonin. Not to dismiss that question at all, but just to truly think about
no, you're not.
What helps. Yeah,
I haven't looked at it in that way.
Let's talk about it, really what that is, because we talk root cause in various types of medicine and healthcare, but it really is the root cause is our change, high, low, declining hormones that cause those symptoms.
No amount of fish oil caplets.
Absolutely. We cannot ashwagandha ourselves out of osteoporosis, heart disease, all that. We can't. Even though supplements like that do have some evidence. But if you want strong evidence with solid numbers behind it, it really will be the hormones. But not every woman, don't let me imply that every woman needs that. Every woman, I'm back to, deserves the conversation to understand that, to make a solid decision for herself with her practitioner, and her practitioner absolutely 100% needs to respect that and not push any agenda or whatever, but truly inform a woman and let her decide.
2 more questions.
Mm-hmm.
Nicole wants to know why joints are affected by menopause and what hormone helps that. Is it testosterone, progesterone, estrogen, or is it all 3 that help the actual joint pain?
Yes. What is up with the joints, right? We feel old when we snap, crackle, pop, right, crispy,
It's
out of the
raining
bed.
today, and I swear I am hurting from the second I stepped out of bed. Yeah.
We have a intake scale called the menopause rating score, menopause symptom rating score. And I put that on there specifically for women to answer because it includes joint pain. When we're like, my hip, when it's typically estrogen. Estrogen is a natural anti-inflammatory. Think about when you're fertile, when you're younger, you're bendy, stretchy, all the things. And then when estrogen goes away, you lose that anti-inflammatory part. Yes.
We moan and groan.
Exactly. You're grunting, getting out of the bed and getting out of the front seat of your car. But that is where it is. And commonly women will go, I have a hip pain or whatever. Well, it's arthritis, but nothing's really seen on x-ray. We can give you an injection. That probably isn't the best way to go if you're a midlife woman. Let's talk about hormone therapy first, because let's get a little bit of that estrogen back on. I cannot tell you how many women have come back and said, my thumbs and my hips no longer hurt. And this is the only reason I can think of is I started hormone therapy. And I'm like, yes, girl, because that's what it is. Does it work forever? No, because we are aging in one direction, but it sure is helpful. For cell health. And when our estrogen is low, we as women know where all the estrogen receptors are in our body, and they're everywhere from our hair down to our toenails. So,
okay, finally, my favorite question, and I think it's my favorite because, well, first of all, she did not word it quite how I'm going to word it to you today.
Thanks, I think.
She was a little bit more blunt. But it also quite literally pertains to every woman as we hit perimenopause age. And it is, what's up with the weight gain?
Oh, God
and
bless.
I know we should be eating right. I know we should be eating those eggs I talked about. But
that didn't help. Let's be honest.
Come on.
It does not help.
Come on. So again, is that an estrogen thing?
That is a whole body thing, and it's all the above, honestly, because...
And that was Kendall, by the way. Shout out to Kendall.
Thanks, Kendall. Way to ask the good question.
Yeah.
Our body composition changes through no fault of our own. When estrogen goes down, progesterone goes down, testosterone goes down. We get central weight gain, more visceral fat, more fat here. Fat around the belly acts like an endocrine organ. So it is the body's way of kind of going, I'm going to squeeze a little estrogen out. But it's also squeezing cortisol out, which looks very similar to estrogen in its molecular structure. Cortisol is our kind of fight or flight hormone. Poor sleep, all of that cortisol wants us to hold on to everything we're eating, hold on to the calories. We lose muscle, we gain central weight, puts us at risk for prediabetes and makes us insulin insensitive or whatever. It lowers our insulin sensitivity. So it is a rare woman who gets out of the perimenopausal, menopausal weight gain. It is not a diet.
And we do not like them.
No, that I would say, and I have told
They're
women,
not my friend, and you're dead to me.
Women, I was like, this is the hardest thing to answer and fix, because it truly is, you are not doing anything wrong. But if you start eating less and exercising more, your body holds on to it more, because we have our body 1.0 that we have mastered. We know how to eat. We know how to drop 7 pounds to fit in that dress by Friday. It does not work. It doesn't work going forward, literally, because hormones tell our body and our cells what to do. And when they have changed roles and they have retired, the other hormones like cortisol and things like that come in and try to replace that as we're aging rapidly after that point, from a frailty and a chronic condition standpoint. They come in and they become the boss. So the body is super stressed. It's not got its fertility hormones. We become stressed, and then we end up being in this cycle. But if we are not super conscientious with nutrition and movement and in a different way, not, going out and blasting cardio an hour a day every day and dropping our calories to 800. I've seen women gain 20 to 30 pounds by doing that. And it was this interesting phenomenon.
It's a very good excuse for me not to go to the gym.
Right, exactly. Well, let's just talk about it. So, and that's a very good question, and it is not untreatable. And I would say stay tuned for that, meaning there are other things that have emerging evidence like lower dosing GLP-1s or GLP-1s in and of themselves.
That is one question that I was going to get to, and I've run out of time because a lot of the things that you were mentioning with the lowering the blood sugar, I can't remember how you said it, and all these other things that also helps with that too. So
absolutely.
And like you said, so much more evidence is coming out that we need to really be paying attention to that.
Absolutely.
Even though it'll probably change in 10 years and they'll say, oh, it's killing everybody. So
yes, I think
can't win for losing.
Yes, working with emerging evidence is where we need to be. We don't need to wait 10 to 17 years for a society or a medical group to come up with guidelines. We need to practice to the best of our ability, know how to interpret emerging evidence as it's coming on board safely and confidently. And I think that's how you can impact women's health today and not waiting for something to come down the line in the future from a society of guidelines that are based in evidence, but still very narrow.
Well, and it's conversations like this that really go so far in helping people understand and breaking things down into layman's terms, which I only speak that. So thank you so much for being here
so
today.
Welcome. Thanks for having me.
We're going to have a part 2 because I have a whole nother book of questions.
Yes, we could have some parts, lots of parts.
Yes. Thank you so much, Jamie.
All right. Thank you.
Thanks for listening to What's Up Wake with Melissa Wistahuff, presented by the publishers of Carry Magazine, Wake Living, and Main and Broad. Follow them on social media at Carry Magazine NC, at MB Magazine NC, and at Wake Living Magazine. Visit each magazine's website at carrymagazine.com, mainandbroadmag.com, and wakeliving.com to check out the latest digital edition of each magazine and find pickup locations. Be sure to subscribe and leave a 5-star review to help others find us. Music provided by Angie Bagley and Chris Bagley. This show is produced by Podcast Carry.
What's up,